Okay, so we're going to get started. This is our third webinar in the series on providing trauma-informed care during COVID-19. As a reminder, this is a free training and it's funded by grants from the Monmouth County Department of Human Services and is a result of a collaboration between the Society for the Prevention of Teen Suicide, the YMCA of Greater Monmouth County, and the Mental Health Association of Monmouth County. Today, we'll be covering suicide risk and what you need to know right now. Our faculty today. So we've got some new people here today with us. Joining Maureen Underwood are Susan Talone and Nicole Diamore-Nolan. Nicole is the project director of the Adolescent Suicide Prevention Grant for the Mental Health Association of Monmouth County. She is a lifeline suicide prevention trainer and she works with communities and schools in crisis. She's worked closely with Maureen for the last 6 years. Susan is a certified school nurse. She's currently the clinical director for the Society for the Prevention of Teen Suicide. She is also a lifeline suicide prevention trainer, and she spent her career in the field of psychiatry with a specialty in suicide prevention and contagion. As you can hear, your faculty team today is the right one for this job. By week 3, I think we've got the hang of these Zoom webinars. I'll be in the chat today helping you with any difficulties, and your content questions should go in the Q&A section. We will address as many as we can at the end of the webinar today, but those we don't, we will write answers to and add to next week's workbook. Today, we're going to be addressing, among some other things, the clinical challenges of the increased suicide risk, of not being able to assess clients face-to-face, and the development of safety plans. Maureen is going to pop on now and talk about how we're going to do all that today. Hi, Maureen.
Thanks, Marnie. I want to welcome all of you and thank you all for coming. As you could hear, you've got a great team today. We have lots of years of combined experience. We're actually not telling you the exact number because if we did, you'd probably do the math and you'd figure, you know, that I truly am older than dirt, so we don't want to go there. But, you know, the experience that we have is working with people who've thought about suicide, folks who've made suicide attempts, and with families who have lost someone to suicide. And I think I can speak for all of us collectively that this latter group is really where our passion comes from. Those of you who have experience in the field know that if you can prevent one person or one family from taking that unspeakable journey following a suicide, it's worth every ounce of energy, time, and effort that you put in. So for those of you who have a little experience with this, hopefully you're going to learn some things and you're going to find out what you need to learn, because obviously an 1.5-hour course in suicide assessment isn't really a lot, but we've got some great resources for you. And those of you who have experience, hopefully what we're going to do is validate what you already know. And maybe you'll be able to kind of share some of us with that in the chat and things that we're doing. So let's take a look at why we're paying attention to suicide related to COVID today. Obviously, there's a lot of concern about a potential increase in suicide really across the population. There are worries that children who might have been referred for evaluation by school counselors when school was in session have spent months without either the assessment or maybe the treatment they needed. And then there's that effect of shelter in place, that lack of structure, that limited ability to use coping skills. I know you all can add to that list. You've done that already. So there's lots of things going on that could certainly increase the risk. People with mental illness going into this pandemic may see an exacerbation of their symptoms or even the presence of new ones related to COVID. I don't know if all of you noticed yesterday, but Michael Phelps was in the news. And he talked about how this was the most difficult time he has ever experienced in his life. And he hinted about having, I think it was dark thoughts. You know, my guess he was referring to suicide. So I think that that's what you certainly can see. And then we've got all those worried well who never really, were involved in any kind of treatment before, but a lot of them may have been pushed back down to the bottom of Maslow's hierarchy, and they're feeling that diminishing capacity to meet their basic needs. The other thing that's of a real concern to those of us in the field is that increase in gun sales. Those are indeed lethal weapons. That is the most common way people complete suicide in this country, is by firearms. And, there's been that increase in dissension around the country, opening under those kind of vague safety regulations. And you see some of those protests where people are carrying not just flags, but they've got guns with them as well. It's really quite a potpourri. And we have to remember at the end of the day that although the causes may be new, the solutions are not. The same techniques that you used to assess suicide risk in the past are exactly what you're going to do right now. Yes, those triggering situations, the answer to that question, what's going on in your life right now that makes you feel like you'd rather be dead, may be, and probably may be, COVID related. But where you go after that follows your standard risk protocol. And I think as you can see, as we take a look at the bottom line during COVID, which we're going to see on our next slide here, is that there are those life changes and the things that come from COVID that can increase possible risk. So we have to be more on alert now, I think, than we ever did before. Everyone might be potentially at risk for suicide, and I think you just want to consider that even with the kids you're working with. It's always important to incorporate that risk assessment into your clinical conversation. And you'll notice as we go through this, we talk about a clinical conversation rather than a clinical interview. I have learned through the years that if I have a conversation with someone about suicide, rather than do a checklist of interview items, I get so much more information, and the intervention actually starts as we're doing that assessment. So we're going to give you some of those techniques and tools today. In that conversation, as you all know, it's really important that you talk about this early. If you wait till the end, I'm sure you've all had that experience once or twice. I know I have. I somehow I just didn't think it was a risk factor. And then I ask at the end and I get, yeah, I am thinking about it. It becomes not just an anxious making moment for me, but for the person I'm talking with as well. So it's really important, with these things going on with COVID, lots of people are having thoughts about suicide. I wonder if that's ever entered your mind. And when it does, it's really important that that become the primary focus of treatment. Even if somebody came because of job loss or depression or anxiety, you need to move to those feelings about suicide and keep a focus on those for quite some time. So I'm going to turn it over to Susan now, who's going to take us through the next step in this process.
Thank you, Maureen, and welcome everyone. COVID certainly has presented us with our challenges, and suicide assessment has always been a challenge, but now more than ever in this world of virtual reality, we are challenged to sharpen our assessment skills even further. What we know for sure is that we cannot help our clients until we really take an honest look at our own beliefs, values, and experiences with suicide. So in this activity, I want to bring your attention to page 4 of your workbook. And I really want to encourage you to fill out these questions in an open and a very honest way. And let me just go over the questions with you. What words come to your mind when you hear the word suicide? How have you been personally or professionally affected by suicide? What is something you think about suicide that you wouldn't want anyone else to know? What can you understand about suicide, and what can you absolutely not understand about suicide? I'm going to give you a few minutes to sort of think about those questions and really try to be honest with yourself as to what your feelings are about suicide and how you really feel. Because what we know is we can't help our clients until we really get in touch with our own stuff. Thank you for taking an inner look at yourself with me, and I invite you to reflect on that as we move through this webinar. And now we have a poll, and I really want to ask you, how confident do you feel assessing suicide risk? Let's start with this. If you could take a few moments and fill out the poll, we can get an idea of where we're at.
All right, Susan, so the answers are coming in. About a quarter of the people have already answered, but we need to give them another 10 seconds or so, I think, to get everybody. I'll keep you posted.
Okay.
All right, Susan, the answers are slowing down. I'm going to end the poll, so I think we have a representative sample here. I'm going to share the results. I think you can see on your screen, Susan, that the most popular answer here was somewhat, with 57% of the people saying somewhat.
And you know what? That doesn't surprise me. And I'm actually glad to see that response, because the truth is that no one is ever 100%, comfortable assessing suicide. We always have a level of uncertainty when we're assessing suicide. And nor should we be 100% 100% of the time, because we're always in a critical life and death situation. So one of the things that I just want to leave you with a few tips to sort of move yourself up that level of comfort, is that if you can keep the assessment in a compassionate, calm conversation, you're going to be much more comfortable, as is your client. So you want to pose your questions in an honest way, in a calm way, and I think this alone will increase your comfortability. Nicole's going to help us look at suicide in a different way as we go through our assessments that I think will really help.
Thanks, Susan. Hi, everybody. Good afternoon. So now that we've already kind of looked at ourselves a little bit, the next step in our webinar today is to look at suicide in a different and creative way. On your screen, you guys are going to see 3 definitions, and these are from the Center for Disease Control. And I want to open up a dialogue in the chat. Go ahead and read these 3 definitions and let me know what you think about them. Do you like them? Are they a little too medical for you? Is there something that you would change? Whatever your gut reaction is to these 3 definitions, I want to hear about it. And I'm going to be watching in the chat to see kind of what comes across. So we have suicide, suicide attempt, and suicidal ideation. What do you guys think?
It's a quiet group today, Nicole.
Mm-hmm. Okay,
so
good direct definitions, accurate descriptions, good. You're comfortable with these definitions. Nice. This is, pretty typical of, what we get when we go out and we do some training. Is there anything that you guys would change? Totally fine that we have some slow readers. I'm right there with you. Intent is definitely important to have. Yep, you guys agree. All right, so I want to move, right, okay, so now I'm seeing a little bit of disagreement. Good. Good, you guys. All right, I'm going to move us along to our behavioral definition. And I want to point out a couple of things why this is valuable, but 2 key points. But let's just kind of look at the definition first. It's an attempt to solve a problem of intense psychic pain with problem solving that is impaired by skill deficits or psychopathology. What do you guys think about this definition in comparison to the other 3? The first time I ever came across this was one of the first trainings I ever watched Maureen present. And as a clinician, I felt really empowered. I felt that that was the biggest difference for me between this definition and the other ones, was that I could actually do something for my clients now, right? It brought me back to the basic skills that I learned in graduate school and through all of my training, was that problem solving piece, right? That's what we do every day with our clients. So while suicide may be overwhelming, the idea of helping somebody through it goes right back to the basics. those impaired skill deficits, identifying that, and walking your client through it. I think the other piece of this is the beginning. It's an attempt to solve a problem of intense psychic pain. We're being empathic and we're being kind. You know, we're remembering that our clients are people and that there's feelings and emotions attached with what it is that they're going through, and that we can lend hope to them in these situations to bring them out and to start building up those hierarchy of needs that they have once again and moving forward. So that's really why I like this definition in comparison to the other three. Well, certainly it serves a purpose, right? Intent and all of those medical terms that we really, really need. I think this one gives us a platform to move forward with our clients and not get stuck on worrying about how to assess suicide. Okay, so before we get into what we're going to call our characteristics of suicide, we wanted to bring up some special risk populations that we know have been, you know, on the forefront of everybody's mind during COVID. We have the LGBTQ population. Certainly for a number of reasons, COVID may be, you know, especially challenging for them. You have adolescents who are perhaps at home in hostile situations where family members aren't supportive. Maybe they haven't come out yet. Across the age spectrum, we may have isolation from peers or partners, certainly adding to the stress that we're all feeling during quarantine. 18 to 24-year-olds. We knew already, especially here in Monmouth County, that this was a high-risk population for suicide to begin with. But now you add some more situations that could certainly make somebody feel hopeless. And you think about, you know, determinations about graduations. There's only virtual graduations at this point. You have kids coming home to not what they expected, no spring semester, no closure. Certainly jobs are on hold, interviews are on hold. Companies don't know where they're going to be financially, if they can even bring anybody on. And student loan debt is going to be starting. You know, I'm not sure what the relief looks like for, you know, recent graduates or any of that, but it's certainly some complicating things to add to a lot of our clients' lives at this point. And lastly, we all know there's an increased risk for domestic violence while we're at home. Moving right along, we're going to talk about the characteristics of suicide. Now, you can see the reference at the bottom, and this is from Edwin Schneidman. He is who we champion as the father of suicidology. And in 1985, he came up with 10 commonalities of suicide. We've condensed those into these 5 characteristics. The first one is suicide is perceived as an alternative to an unsolvable problem. Crisis thinking is predominant. Ambivalence is usually present. There's an irrational quality to problem solving. And lastly, we know that suicide is an act of communication. I'm going to hand it over to Susan. She's going to walk us through our first characteristic.
Thanks, Nicole. It's really true. Suicide is often perceived as an alternative to that unsolvable problem. And it seems like it's their only way out. And so many times the components of that thinking have to do with a disciplinary crisis, humiliation, loss, or precede a feared event. So I thought it would be helpful to tell you about a case that I had that I thought really brought these points up. While I was working in a school that was in the midst of a suicide contagion, I had a student with a diagnosis of ADD, attention deficit disorder. And this student had, you know, asked his parents, had made a deal with his parents that he wanted to go off of his medication because he was tired of it. He didn't like being on it. And he wanted to go off of it. And the parents said, yes, as long as your grades stay up. So he went off his medication. And one day he went into class and the teacher was handing out a test and he apparently had failed. So when the teacher handed him the test, in a soft way, he said, you know, something about the failing grade, like you need to bring this up or you need to pay attention to this. Whatever it was, the student felt embarrassed, felt humiliated in front of his friends. He left class, he was upset, and the teacher could tell he was upset. So he called home to just sort of say, you know, this is what I'm seeing, the grades are starting to go down, but, you know, I just wanted to let you know. By the time the student got home, the parents had been arguing. He walked into the argument. They were angry with him. The mother said, I'm going to leave. I'm going to fill the prescription right now. You're back on medication. She left for the pharmacy. The father laid down the disciplinary act. You're grounded with no video games. That student, before the mother returned home from the pharmacy, had gone into the bathroom and hung himself. So this case highlighted to me that he truly believed that there was no way out. And there was a momentary loss of that survival instinct that we know is, you can lose it in a few seconds. And it had all the components. The disciplinary action was, he was in trouble with his parents, with his teacher. He was grounded, no videos. Humiliation was there in front of his peers in his class, and even for himself, because he had set this standard that he could do it without the medication. The loss of autonomy, because he really wanted to be without this medication, the loss of privileges, and the feared event. He didn't like being on the medications. That was his event, and the videos. He was really hooked into that video game, and so he feared that event. So all of a sudden, this problem became unsolvable, and he felt he had no other choice but to die. Okay, so I want to take a poll and ask you some of your ideas as to what some of the triggers are right now as we go through COVID. What have you observed, or what could you imagine some of the triggers could be during COVID?
Susan, people are already weighing in. I want to remind anyone, we love to see your answers in the chat. Notice in the chat that you can select whether you chat to all panelists, that's just the 4 of us, or whether you chat, which I prefer, to all panelists and attendees. That way everyone can see your triggers and the ideas you have. All right, so in the chat, people are writing financial crisis, being isolated, substance abuse exposure. People are still weighing in on the poll too. I'll keep you posted, Susan.
Okay.
Just feeling overwhelmed, immigration status, disconnection from friends, feared loss of relationships, fear of failure.
Yeah.
All right, so I'm going to stop the poll and share the results because we're pretty close to getting everyone's input there. So I'm sharing the results. The most common one, Susan, was stuck in toxic home environment, but there was a lot right after that. Unable to use typical coping strategies, loss of hope for the future. And like a lot of those ones in the chat I just told you about. Lots of people talking about financial crises, loss of socializing, and isolation.
Yes, everybody's right on target. This is what we're hearing from kids. We're hearing it across the age span from adults. The financial picture is a huge thing. And one of the things I've been hearing about is that children are really concerned about their parents for the first time in their lives. They're actually seeing their parents unfold. And that is really, that's where they find their safety. So as the parents are experiencing so much stress, so are the children. And that toxic environment that everyone identified is so true. There's abuse, substance abuse, domestic abuse, and yes, even sexual abuse. The close quarters has become very toxic for so many people, and I agree with this poll. They've nailed it. Let's go to the next slide. One of the things I wanted to talk to you about was in suicidal thinking, there's always a presence of crisis thinking, which is really when we believe that what is happening in our lives is beyond our resources or skills to cope with. We don't believe that we have the skills to meet the demands of the environment. And so that creates a level of being threatened. And this can trigger our fight or flight response, which affects the limbic system in the brain. And this affects our ability to think, to learn, to reason, and most importantly, the ability to make good decisions. So our thinking becomes constricted, emotional, and reactive, and that can be dangerous. So crisis thinking can create that feeling that there's no way out. And I just want to say one thing that I think is very important today, and I want everyone to hear this. If you need to remember that no one chooses to end their biological existence. what they are choosing is to end that intense emotional pain. That's what they're choosing to end, not their lives, but the pain. And this unsolvable problem is creating that pain. So if we remind ourselves that, we help our clients every day deal with unsolvable problems and recognize that they don't necessarily want to die. They just want this problem to be alleviated and this pain to be diminished. And I think if we keep that in mind, we can approach our assessments in such a different way. Okay. What I want to do with you now is an activity that I think is very powerful. And I do this in a lot of my trainings, and I get good response in terms of people saying they haven't really thought about this before. I want you to take a few moments and indulge me, and I want you to bring yourself back to one of the hardest times in your life, one of the most difficult times in your life, one of the darkest times of your life. And I don't want you to think about what you did to get through it. I don't want you to do that. I want you to think about how you felt during it. What feelings was going on for you during this really critical, difficult time of your entire life? I'm going to give you a few moments to sort of tune in. How did you feel? Okay, I'm seeing some answers coming in. Wow. Trapped, yeah. Oh, you guys, yep. Thank you so much. Hopeless, yes. Sick, isolated, terrified, wow. Unloved, trapped, scared. Incredible answers, yes. Embarrassed, hopeless. Okay, thank you so much for sharing. Broken, wow, and helpless. So you have highlighted for me my exact point that we have all felt these intense feelings of critical thinking, of crisis thinking. Most of our clients are feeling exactly the way we've just described in the chat. So we really can understand so much more about suicide than we ever thought possible before. And I want you to remember this activity because this has helped me so much, and it helps you connect. As that client is feeling this way, you can remember feeling that way, and all of a sudden you have, a way of helping them through it. Because what helped you was you had support during that time. Somebody helped you get through that dark time, and that's what you're doing for your client. Now, Nicole is going to take us through another way of working through this assessment. Nicole?
Thanks, Susan. All right, guys. So anybody who knows me knows that this is probably my most favorite slide out of all of the trainings that we do. And it's for two reasons. One, it teaches us as clinicians how to look at suicide and how somebody gets into the bottom apex, that bottom of the triangle where suicide is the only option. But it's really been an intervention tool that I've been able to use with clients that have worked so wonderfully in keeping the visual of how they end up down there, how they get from a stage 1 crisis all the way to a stage 4, where they're thinking about wanting to die. It brings back in that middle piece, that stage 2 and stage 3, where they're unhealthy and has an idea of how to get back to the top. So what does that mean? If you're looking at this, right, we have an upside down triangle. At the top, we have healthy problem solving alternatives. In the middle, we have unhealthy problem solving. Our yellow line is going to indicate where a triggering event may push somebody over the edge. And then we have the bottom of the apex where suicide is the only option. I'm going to walk you guys through an example, and then I'm going to give you an intervention, on how we can bring our client back up to the top. So we have Marla. She's 42 years old. She's married. She has 3 children under 10. In your work with her, you know that she has a history of depression, and she used to self-injure as a teen. So you guys have worked really hard. She loves to run. That's, her healthy problem solving. She dog trains, on the side. She loves to be with dogs and animals. She travels frequently with her husband. and she always has a weekly outing with her elderly mother. That's how Marla knows that she's healthy, that she's doing good, she's on the right track. Where Marla has worked out that she starts to slip back into those feelings of depression is when she has a lack of the ability to cook healthy, or she's not eating right and she's slacking off there a little bit. That's a first indicator. In your sessions recently, you've noticed that she's starting to drink more frequently than she has been before. She's having nightly cocktails to kind of take the edge off of the day. A daily call with her mother was put in place to kind of replace not being able to go out with her weekly, but they become contentious. Her mother wants to go out. She's not really listening to guidelines to wear masks, and Marla is incredibly worried about her mother getting COVID. She's staying up late and she's binge watching movies. Her sleep is really impaired at this point, and these are all indicators that you guys have pointed out to her that she's really not moving in the right direction, and we need to pull her back up to the top. So what ends up happening? Marla has a triggering event. Her husband is fired from work. He's laid off. They don't know if they're going to be able to bring him back or what the situation may be. But for this point in time, he's lost his job. Her mother did get COVID, so she's currently sick with it. They are very uncertain about how it's going to affect her. And Marla lets you know that she's feeling depressed. So she's right down here at this bottom, at this apex, where suicide starts to become the only option. She really feels that this is an unsolvable problem. She doesn't know when we're going to get out of the COVID situation. She's fearful of losing her mother, and there's a looming financial crisis for her family. What do you guys do? Right over here in the big red letters on the left-hand side, you see ventilate and validate. By allowing her to talk about this, by doing this activity with her, you're ventilating all of those emotions that she's probably buried deep down inside just to get through the week, to deal with homeschooling, to deal with her husband, all of those different complicating factors. And then you're going to do the hardest part. You're going to validate the feelings that she has that is making her feel so hopeless she wants to die. This intervention alone brings your client right back up to the top to healthy problem-solving alternatives where they're using good help-seeking behaviors. And it's reinforced again by your ability to allow them to ventilate, but also more importantly, by validating those feelings and not trying to problem solve, not trying to say, no, you don't. It's going to get better. You have so much to live for. You're actually sitting with them in that darkness. And going back to what Maureen said earlier, you're lending her hope. So I like to do this activity with my clients. I've done it with adolescents before, and they absolutely love it. I had one client who decorated it and hung it in her bedroom, and she would come into session and say, I started to slip into the middle. I went right up. I talked to mom. I got right back to the top. I'm feeling good. We would make the triangle, and in the outside of the triangle, we would draw some coping skills that she would know could bring her back to the top. She knew when to contact me, when to contact other resources like the National Suicide Prevention Lifeline or Second Floor or anything of that nature. And we use this in family sessions too. Like mom was very well aware of what her triggers were and what the constructed tunnel looked like for her daughter. And that was a really big piece in maintaining a collaborative process for her safety. So I'm going to move right along. We're going to talk about our third characteristic of suicide, which is the presence of ambivalence. And that is feeling two opposite things at the same time. Now, I'm going to point out a couple of things here, but first we have suicidal ambivalence. And then I think there's an ambivalence that most of us are going through in the COVID-19 situation, right? Daily, we are getting updates where the governor is saying there's no graduations, and then we're slowly opening back up. That lends to the second part of ambivalence, where we lack the perspective or hope that things can get better. And there's a hope, discomfort, and balance, right? Every day, maybe we're a little bit more hopeful, and then something else happens, we're a little bit more just uncomfortable, and it goes back and forth. So certainly for a client who is already experiencing ambivalence as it relates to their suicidality, the news and that type of exposure can definitely put them at, an elevated risk. What I want to say about this is, ambivalence as a characteristic is why you will see, in some instances, stories about a child who has done all of their homework the night before school, but still died by suicide that night. That is ambivalence at its core, planning for the future, but also feeling so hopeless that you want to die. You have a father who maybe planned a trip and died by suicide the week before, even as they were packing to go. What do you do about that? How do you speak to ambivalence in your clients? You talk right to it. Okay, walk me through what happens if you lived, and walk me through what happens if you die. We're going to get into it a little bit more, and Susan's going to talk about it on the next slide. But there's an illogical piece to suicide, and speaking to this question is a little bit of reality testing for them and brings them back down to, no, maybe this problem is solvable with me staying on this earth. All right, handing it back over to Susan now, and she's going to walk us through our fourth characteristic.
Thanks, Nicole. The fourth characteristic is often one of the hardest characteristics to understand because it defies logic. And it actually may signal the disconnection from that survival instinct that we've talked about. And this is that crisis thinking has an irrational quality. And why it's so difficult to understand is because we're logical. We're looking at this as logical people. And so we can see that their thinking is irrational, but they don't see this. They have convinced themselves that this is the reality. So you need to recognize at this point that oftentimes this is when we're trying to lend some hope, but you can't argue with them. If they truly believe that the world will be a better place without them, that no one will miss them, you're better off not to argue with it, but to gently move them to reality. And sometimes that can happen with just one question. You've told me your reasons for dying, and I understand that. What are your reasons for living? And see if you can get them to identify one or two things. And oftentimes it might be as simple as the dog. And that dog is now your hook. Tell me about that dog. How will the dog be without you? Who will feed the dog? Do you think the dog will miss you? And so those kinds of questions gently pull them out of that irrational thinking back into some moments of reality. And that can really, really help. If someone can't give you reasons for living, right there, you know you are at imminent risk. The next slide, and the fifth way that we know about crisis thinking, is that suicidality, there's always an attempt at communication. Always an attempt at communication. I saw this over and over again. And the message usually relates back to that unsolvable problem. So in youth, it may often be that, you know, no one's listening to me. I told you I couldn't take this anymore. And now, you know, I'm going to have to do this to get you to really understand how serious this feels for me. Oftentimes it can be an FU to the parents. You know, I don't want to play sports. Even in adults, you know, it's the same kind of thing. You know, I've told you I can't worry about the finances anymore. I can't take it anymore. So you're not understanding this. So oftentimes there is a communication. One of the, and social networking, you know, pay a lot of attention to social networking. We have found that kids along, and actually adults as well, are communicating what they're feeling on social networking, waiting for someone to respond to them. So again, watching those levels of communication. And one of the things that I have done, and it's been effective, especially in youth, I can say that, you know, something like this, you know, it seems like you've got a message to send. And it seems like, you know, you want to send that message to someone. Is there any way you can send that message and stay on this earth? Is there any way that you and I can partner together and get that message sent to your parents or to your wife or to your children and stay on this earth? And it's that partnering, that we word, that adjoining word, that gives them that level of hope that might bring them, you know, out of that period of despair. And I think that's really important to remember, that adjoining word we, as we work with our clients. Okay, I don't know about you, but this is a heavy topic, and sometimes we really need to come up for air. So let's take a breath, get something to eat, go look out the window, go pet your dog, stand up and stretch. I'm going to go get something to drink. I'm going to come back in 60 seconds, and I'll see you in a minute.
All right, bye, Susan. I don't know about you guys, but I'm terrible at drinking water, so I had to buy this special cup to remind me how much water I need to drink throughout the day. Nice little break there. Lemon and basil water. Nice and refreshing.
I'm back.
You're back.
A bit refreshed.
Yes.
Ready to go.
Mhm.
So let's move on.
Okay.
Nicole, take it from here.
I will. All right, guys. So now that we've gone through our 5 characteristics of suicide, what I would like to do is just a little bit of a recap on how a suicidal crisis develops. Certainly, we know that our clients have the presence of risk factors. We're not denying that. We know what they are. There's a perception of overwhelming problems that seem unsolvable. That is your very first characteristic of suicide. Suicide seems egocentric. So what do I mean when I say that? Suicide has now become consistent with your client's view of self. I will tell you this is probably the highest indicator of imminent risk, whereas in before you may have had a protective factor where somebody couldn't see themselves completing suicide. You have somebody who maybe now is moving into the research phase or even the rehearsal phase of a plan, really, coming in line with their ability to see themselves going through with the act. So watch out for that and make sure that you're asking questions about how suicide may align with their view of self. Somebody may say to you that they could never see themselves doing it because of, as Susan said, the dog, or maybe religion, or maybe their family or other things. You want to hone in on those protective factors, however illogical it may sound. If you really believe that the cat, is what's going to keep this person alive, you talk to the cat every session and you say, yeah, that cat needs you. Fido needs you, I need you, and you lend hope, you work together. Exhaustion of personal family support system resources. This is a complicated one, especially right now for COVID-19. We know a lot of these have deteriorated for our clients, and I think that's why we're doing webinars such as what we're doing today, because we're trying to build those back up. But watch out for those and make sure that you're trying to replace those. Online support groups are coming forward. There's been a lot more coming every day. So you want to replace those. You want to do as many coping skills as possible that lend to protective factors. The triggering event seems like the last straw that pushes them over the edge. Think about the tunnel that we went through. They're down there in that apex. They're going to need some help pulling themselves out. They feel that there is no other way. It goes right back to the top of this is an unsolvable problem. Nothing that I can do is going to solve my problem unless I die. And we need to speak to that through ventilation, validation, and a little bit of reality testing. Okay, so now that we've kind of figured out that we're worried about our clients, we're going to go into step 3, which is assessing the basics. Risk assessment basics. As Maureen said in the very beginning of the webinar, always consider suicide to be a risk. You never want to live with the guilt that you didn't think that this was possible for your client. Always keep it in the back of your mind. You're going to ask about it early in conversation. Like Maureen said, I know there's nothing worse than being in the last 5 minutes of a session with your client where they say a little something that you're worried about and having that feeling in your gut that you need to go in a different direction. You have a very limited amount of time to do so. Ask about it early. Again, it's a conversation, so it's not so much this interview that we've been focused on before, perhaps. If you're having a conversation, two things can happen. Either your client's going to affirm your worries that they are thinking about suicide and your session is going to move in a completely different direction, or there's going to be a sense of relief there because your client is not going to indicate that they're at risk for suicide. You're going to assess their safety, which is a little complicated, especially since we're at home now, but you're going to do that and you're going to do it early. And then you're going to determine the most impairing behaviors to adaptive functioning. Now, if you're at the early conversation phase and it's you've learned that your client is thinking about suicide, you're not worried about adaptive functioning at this point. Anybody who's thinking about dying really doesn't have any adaptive functioning. You're going to move directly into trying to get that person help. But if you're somewhere else, but you're still concerned, what is impairing your client to function, and how can we get them back to the top of that tunnel, to those healthy problem-solving alternatives? So how do we determine imminent risk? There's a predisposing vulnerability. We know that our clients have a readiness to act. That may be a plan, that may be rehearsing, researching. We have the acceptability of suicide, back to that egosyntonic stuff, loss of supports, and failed protections. All right, guys, we're going to come back in with another poll right now. And what I want to hear from you guys is some of the telehealth challenges that you guys are feeling or experiencing. Maybe you're even worried about when we're, home for COVID-19.
All right, so I launched the poll, but I'm not seeing, answers are starting to come in. There was a lag there for a minute. I thought maybe no one cared about this one. No, it's a hot topic. They're jumping in now.
There we go.
Yeah, and I've asked you again to share them in the chat. Again, as a reminder, you can, if you want to put them in the chat, let's everyone see it by having it go to all panelists and all attendees. On a side note, lots of you are chatting that you want the recordings. I won't be able to keep track of all that from the chat today. If you want a recording, email me, marniewrote@gmail.com, and I put that email address in the chat. Okay, Nicole, back to our topic here.
Okay.
Lots of, you can see all the chat things coming in. And as far as the polling, I'm going to end the polling and share the results. There's a lot of concerns about missing that physical cue.
I know.
That's a big one, and you can see all the chats coming through there too. I think, Nicole, can't you?
Yep. Yeah. One of the ones that somebody brought up that we hadn't spoken about earlier, but it's definitely something to bring up is client privacy, especially when they're in the home, especially if they're an adolescent. Parents listening in on sessions, that's certainly a challenge. That we have to work through, and we have before. What I'm seeing here, we're missing the physical cues. We're going to talk about that in a little bit as well. Can't physically get immediate help. They can disconnect if they get upset. For me personally, I think that's the one that I'm the most worried about, is what do they do if I ask a question, or I'm moving in a direction where I'm telling them that I think they need to get immediate help, them just logging off. All of those different types of things. What I would recommend in that point is think about policies and protocols. Think about setting those things up in advance before a crisis. A lot of the work that we do, Susan, Maureen, and myself, as we, consult with schools and communities, is putting these plans in place before a crisis arises. The hope is that you never need to use them. But we know, right, one of our characteristics of suicidal thinking is in a crisis situation, you're not in your best state. Your mind is clouded. So if you have a reference guide even next to you, at your private practice, at your agency, or that, anybody under you can be using, you just grab it quickly. They've clicked off, what number you're calling right away. Maybe you don't want to call 911. You want to call the police department immediately so they can do a well check. Knowing where your client records are so that you have their address in case you do need to do something like that. A lot of the places that we've worked with before, I've said having these things in place before a crisis actually helped them tremendously with their burnout afterwards from, having to deal with the crisis themselves, and being able to return to work and feel confident and competent that they handled the situation in a way that was best for their client. So I would kind of implore you guys to explore that. And if you are in an agency, see what those are, see if there are COVID specific ones. Susan's going to talk a little bit later on in our webinar about what referrals look like right now in Monmouth County. And, if you have families who don't want to go to the hospital because they're afraid of contracting COVID and all of that different stuff, we're going to definitely address that. But that's kind of my advice on those two as we move through, this training. Okay. So before I hand it back over to Susan, we're going to talk quickly about behavioral indicators of imminent risk and those warning signs, right? Insomnia. One of the first things that I learned, always, even as a child, things go bump in the night. We know that not sleeping breeds problems for our clients, suicidal or not, anxiety, depression, all other types of, complicating factors that go into our clients' lives certainly affect their ability to sleep. We know that people aren't sleeping. We know that structure has kind of been wrecked a little bit for everybody. So getting our clients on a healthy sleep schedule is going to be, hard, but something that's a priority. Panic and agitation. I mean, we know that this is going on in homes. Think about Marla. She's at home with 3 kids under 10, getting all of them to homeschool while dealing with all of the responsibilities that she has as a wife. You know, there's certainly some panic there about her mom and whether or not she's going to be healthy. There may be agitation about dealing with the kids. You know, these are real feelings that people are going through as we move through the COVID-19 crisis. Impaired attention and concentration. I don't know about you guys, but I'm constantly on Zoom. I'm constantly on the phone, FaceTiming, between my children having homeschooled, between me being on meetings, all of these different things. And that's increased my attention and my ability to concentrate. I've found, you know, that I'm a little bit more limited in there, you know, and that's certainly a risk factor for a lot of the people that we work with and that we're seeing across the board. Lastly, acute intoxication. We know that, you know, substance abuse is something that we worry about with our clients who are suicidal to begin with, because it further deteriorates their ability to think in that moment about whether or not to switch on and off their instinctual, you know, will to live. But further, I don't know about you guys and what you've seen, you know, on Facebook or on social media, but I think the big joke is, in order to handle being at home and dealing with this quarantine, you got to be drinking. You know, a lot of the jokes that I see online is, when is an appropriate time to start drinking during homeschooling? Or when is, you know, I saw another one the other day that was like, you know, little did my boss know I was having a mimosa during our, you know, staff meeting. So I think a lot of this has become kind of the social norm, in a sense, to bring humor and light to the situation. But I worry about that specifically with a lot of our clients, that, you know, it's now been accepted. So that's something to kind of look out for. I don't know if you guys have seen that or you guys worry about that as well, but it's certainly something that's going on in our society. I'm going to hand it back over to Susan, and she's going to bring us through assessing intent.
Thanks, Nicole. I think that what we need to pay attention to, just this slide alone is important. Remembering that, you know, intent is really, the goal of suicidal behavior is to replace the experience of pain and helplessness and hopelessness or powerlessness that COVID has created for us, or any other situation. So it's really an attempt to replace that experience. They want away from that. And I think that's important to remember. So when we're looking at intent, if we can look at the next slide, there is expectancy of attempt. I think it's really important to ask them what they expected from the attempt, because we can't assume that we know. All right, so for an example, if you're going to ask somebody, you know, what did you think was going to happen when you took those pills? Sometimes you might hear, I just wanted to go to sleep. I just wanted an escape from the pain. I didn't really think it was enough to be fatal, or you know, I didn't realize. On the other hand, you could have a teenager that took 8 Tylenol and really had the intention to die because they thought that was enough to take their life. So I think that's really important to pay attention to, and really check out with them, you know, what did you think was going to happen with that attempt? I think too that if you look at the questions here, you know, to ask these specific questions, I think this is really important. Let's just go through these questions. Why is the person having these thoughts now? How long have they been having these thoughts? This is really important. How often do they have them? Have they made specific plans to carry out the plans, and really drill down into those specific plans? What are those plans? Do they have access to means? Does the person have reasons for living? If so, what are they? Have they attempted suicide in the past? And I think most of us know by now that, you know, history is a strong indicator of the future. And that last question, have they rehearsed this method? And I think this is really important. I even have, I always think of a case that I had with a kid that I didn't think he was that suicidal until I drilled down a little bit further. And I said to him, he was talking about drowning. And I asked him, well, you know, if most of the kids in our area go boating and that kind of thing. And I wasn't quite sure the severity of the attempt. And I said, tell me a little bit more about that. And he described a bowling ball that he was in the back of his mother's closet in a blue case that he was going to take boating with him to tie around his shoe. I mean, and on he went. And I could quickly tell that if I hadn't asked that question, I would not have realized how serious that attempt was. So those specific questions are very important. And I think too, if I can give you some tips here, if you find that this person does not have reasons for living and there is imminent risk, you probably will know that you're going to go to a screener at some point, or you're going to have to get this person assessed further. If you had to call screening, all these questions in front of you, they're going to want to know. So having asked them already and having that information makes you prepared in a very strong way. You want to use quotes, exact words from your clients. You want to speak about their specific behaviors that support your concern for suicidal risk. Again, past attempts, and not just that there were past attempts, but how serious were those attempts? What were those attempts? And one thing I want to say in the world of COVID, if you're really concerned at this point, to stay with your person virtually or on the phone until someone arrives, or arrange it so that they are not alone. Have scheduled times, phone calls in the morning or in the afternoon, you know, to really keep checking in on these people. And that's what we call that radical availability that we will so often speak about. And the one thing that research has shown us is this follow-up is so important to give your clients, if you're concerned about them, that following up piece gives them the message, you are not alone. And I think that moving to this slide, I just want to point out a couple things on this slide. We talk about being prepared with a sequence of questions. We talked about that in a logical and direct way, but checking out your understanding is really important. So how I do this is on a scale of 1 to 10, you know, 1 being, you know, you feel awful, 10 being you feel fabulous. Where are you on this scale? Because oftentimes I might think they're at a 6 and they may tell me that they're at a 3. So I think checking out your understanding is a very powerful piece. And again, drilling down for details and taking ideation as seriously as behavior, because thoughts lead to behavior. And the last thing, consult, 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 and document, document, document. So very important. Our next slide. Nicole, you're going to help us come up for air?
Yeah. All right, guys. So these are kind of, you know, Maureen and I have a tendency to go back and forth and joke about some of the memes that we see online. And these were some of the relevant ones that we've been sharing back and forth about COVID as they relate to mental health, certainly. And, you know, just to come up for air a little bit, have some, you know, laughter. I'm pretty sure that we all at this point, you know, maybe, I don't know, kind of feel like we look like Yoda some days, you know, old Yoda when we're waking up. We're not as, you know, young and fresh into this quarantine as we were baby Yoda day one. But my favorite, you know, until this morning was this 2020 commemorative candle, where we're just assuming that at this point 2020 is a dumpster fire. But that one gave me a good chuckle. The other one that I found, like I said this morning, and I just had to add to the slide, is this one over here with the green border, where it says, my favorite part of quarantine is that we were all forced to be alone with our thoughts for a little bit. And everybody was like, absolutely not. I will learn to bake bread from scratch. And it's funny for me for 2 reasons, but also kind of important for the work that we do, that people are at home and they're uncomfortable with how they're feeling. But more so, you know, make all the jokes about banana bread and sourdough that you want. This guy was able to say, all right, I'm going to a dark place. I'm going to start making some bread. You know, so it shows to me that people are able to use some of their skills, whether or not, you know, they think it's, you know, worthy to kind of get themselves through this. But certainly people are at home alone with their thoughts and they're worried. And whether or not they're using the appropriate coping skills is why we're here today. So now that we've had the maybe a good laugh at a couple of those. I'm going to give you guys 3 of my most favorite words. There's 3 other ones that come later on, and some of you may know what they are if you know me, but this is tell me more, and this is the tell me more model. And it reflects the 3 hardest but most important words to say to a suicidal person. It goes back to that point that we talked about earlier with Marla, the ventilate and validate. As a community of humans, it's our intrinsic nature to want to problem solve and help people. We want to say immediately, especially when a child or somebody we love or somebody who has so much going for them is hurting in such a way that they're thinking about dying, that we want to say to them, no, you don't. It's not possible that you could think that way. You have so much to live for. That pushes people further down that apex towards that suicide is the only option that we thought about before. Tell me more opens the door to talking about suicide in a conversational way. A lot of our clients have had these thoughts for a while and have been so uncomfortable with them that they never thought they could tell somebody. And the good work that you've done by building rapport has allowed them to give you a little bit of that door opening to say, yeah, I'm thinking about dying. Tell me more opens that door further. That lets you in. That says, I understand you have some scary thoughts, but I want to hear them. That's so empowering for a client. It addresses questions about suicide from that crisis perspective. It frames suicide as the solution to that seemingly unsolvable problem. By telling them, no, you don't, right? That means to them that you're not really listening to me. No, you don't understand. However illogical it is to them, the problem could be what Susan talked about, something like getting in trouble or a feared event. To us, could seem so illogical, but to that person, it's unsolvable. When you say, tell me more, that allows them to go in a different direction that completely avoids cliches. You're not making their problems sound trite. You're actually listening to them, that this is their whole world, right? I have the example of a teenager who breaks up with a boyfriend or girlfriend, and you know that they're going to get over it because we've had that lived experience. Young people don't. There's more fish in the sea. Well, I wanted that fish. Tell me more. Explain, lets them go there, instead of saying, one day it's going to be better. They don't have the capacity to see that one day. You got to remember that about ambivalence. All right, protective factors, right? We have effective clinical care for mental, physical, and substance abuse disorders. We have restricted access to highly lethal means of suicide, strong connections to family and community support, and support through ongoing school, medical, and mental health care relationships. I think a lot of these are things that we're worried about that have deteriorated in our current situation, right? Strong connections to family and community. The community piece is kind of broken off a little bit. We're slowly getting back there, but it's not exactly where we'd like it to be for a lot of our clients. Family may have become hostile at home, so that one kind of backs out, and we need to, as clinicians, figure out a way to bring it back up. Online support groups certainly do that. Support through ongoing school. School's ending in the next 3 to 4 weeks, and while it may have been a contentious situation at home, my worry is what all these kids are going to do in unstructured time without anything kind of to do. Like, at least in the summers previously, we had beaches or parks or places to go. While we certainly may be able to do that, there are going to be some families who are a little bit more hesitant to going out. We're going to have a lot of kids who are staying home, and it's not going to be the summer that we've expected across the age spectrum too. So we're going to keep moving on. Susan is going to bring us into some questions for a poll on shelter in place and those protective factors.
Okay, so we're going to move into this poll to see what some of the protective factors are. Marnie, let's see, what are feasible protective factors in shelter in place? Let's see what comes of this. Let me know, Marnie, how it's coming in.
I sure will. They're just starting to answer pretty fast and furious. We haven't got anything in the chat yet, but I'm sure that they're going to have some ideas in the chat too for us after they finish logging their poll results. Pets, right? Pets is one of our favorites. Play cards, puzzles, live music online, music, pets, art, readings, webinars, probably not something as heavy as ours. Exercise, family Zoom game night. That's been very popular. Comedy, FaceTime, Okay, so I'm going to wrap up the poll as other chats keep coming in and share the results. Exercise was a very strong response at 84%. And coming in just under that are things like social connection, trusted friend, meditation, prayer. And I think we covered a lot of these really great ones in the chat, Susan.
I think, you know, it's funny, exercise would have been my answer as well. I have, walking has become the only thing I look forward to, not the only thing, but one of the major things I look forward to in the day. So exercise has really been an outlet. I think it's a physical outlet, it's a mental outlet, and all of these are so important. Prayer and meditation, social connection, and trusted friend came in high, which is important as well. As a matter of fact, I want to just highlight this, that for adults, social connection is the #1 protective factor, even before COVID, but it's certainly since COVID. And I think that's really important because adults, you know, we're physically distancing, but we really can't socially distance. We have to stay connected, and I think that's really important. And for children, the #1 protective factor is a trusted adult, which concerns me because so many of those trusted adults are school people or coaches and things like that that kids don't have access to. So that communication, that Zoom calling or FaceTiming becomes even more important. So great responses on this poll. A lot to discuss as we move forward. I'm going to pass over to Nicole.
I am back. All right. Now that we've assessed our clients, we need to stabilize the crisis. We're moving into our 4th step here, and we're going to talk a little bit about crisis intervention. So what is the goal of crisis intervention? It's to keep the client physically safe and alive until the crisis situation has resolved. Pretty straightforward. As we move through that, you know, what are our tools of crisis intervention? Here come those 3 words that are my other favorite set of words: support, control, and structure. Whenever you're presented with a situation, especially in a crisis, what you're going to do is you're going to ask yourself these 3 questions. Does it provide support? Can I maintain control? Does it provide structure? This is a 3-pronged approach. So what you're going to do is ask yourself this, and if any one of these questions you have to answer no to, you don't move forward with that intervention. It's not going to work, especially in a time of crisis. I'm going to give you guys a little bit of an example, right? So you've been presented as either an agency, maybe a clinician, to kind of do an anonymous check-in or a mental health check-in, and somebody wants you to be able to have questions submitted anonymously. All right, let's think about this in the terms of crisis intervention. Does it provide support? Absolutely. You are able to answer questions for people. You can provide resources to the community, to a larger group of people than just those you practice with. Can you maintain control though? Think about this, all right? So people are submitting anonymous questions. What happens if somebody submits something that really indicates that they may be at risk, or something that you want to just do a little bit of a follow-up on? There's no control there, right? This tells you don't even need to go on to the last question of whether or not there's structure, because there's already not control, and it's not going to be something that you do. So this is a great asset, especially when we've trained schools, agencies, and communities before. This is a little quick thing that you can pull out of your pocket, especially in a time of crisis thinking. You just think to yourself, support, control, and structure. If there's only a few words that you guys leave this webinar with today, tell me more and support, control, and structure. Those are going to be the words to live by. They've certainly become that for me. So I want to hear from you guys. Have you developed safety plans during COVID, right? We may have done it before, but what I want to hear is whether or not you're doing it now, or you've had to do that with your clients.
All right, I'm launching the poll here.
All right, Marnie.
All right. Oh, people are so eager to answer. They're answering in the chat. All right, one sec.
Love it.
Yeah.
I love this
engaged audience. Yeah, they're on it. Okay. So the poll results are coming in. This is simple. It's just a yes or no. So it should go pretty quickly.
Oh boy.
I know. It's kind of like a race, yes versus no.
Which way does it go?
So far it's heavier on yes. We're 61% at yes, but answers are still coming in. They're slowing down. I'm going to give about 5 more seconds just to get a sense, but it looks like yes is going to be the majority, but not by tons.
Okay.
Okay. All right. So I'm going to wrap up the poll and post the results so everyone can see. We finalized at yes at 58% and no at 42%.
All right, you guys. So, I mean, we're pretty 50-50 here. It's going to bring me right into my slide. So I don't know about you guys, how you guys feel about this. I make safety plans like early on. If there's a client that on paper kind of looks like to me could be somebody who might be at risk in the future, certainly if there are, some triggering events that may push them over the edge, they have those, those risk factors that they're presenting with. I mean, I can tell you that, it's really lent itself, especially if some safety plan things fall through. So, right, this is a hierarchy. It's an arranged list of coping strategies for use during a suicide crisis. Like I said, I make it early on. There's nothing worse than trying to explain to a suicidal client at stage 4 that they should have been doing yoga, or they should have been listening to music, or they should have been doing muscle relaxation. They look at you like you're crazy, So this is really for when they're in that middle of the constricted tunnel we talked about, that stage 2 and stage 3, things that they can do to kind of bring themselves back up to the top. It's a collaborative process. It's an ongoing process. I think, we revisit safety plans all the time. It's a written document. 1 copy goes to you, 1 copy goes to the client. I've done a lot of sessions before in family sessions where I've gotten the kids comfortable in sharing that with somebody else, whether it be their trusted adult or it be a family member, again, speaking to the collaborative process of maintaining a safety net for our clients. It's got to be brief and it's got to be easy. There's nothing worse than being in a state of crisis and jumbling through a whole bunch of papers, not knowing what it is that you're looking for. So as brief and as easy to read as possible. In your workbook, you guys have a number of resources for this. We have some from Zero Suicide. We have an activity where it's actually walked you through doing one with an adolescent. One of the ones that I like to use is actually a virtual app. It's called My3. You can go on there. The client can download the app. They can give you access to it. What I really like about it is it will give you a notification if one of your clients has updated their safety plan. So the idea is they come back to the next session, you could always say to them, hey, I saw last week when we weren't together, you updated your safety plan. Were you experiencing something that was really stressful for you? Or maybe you were just actively thinking about coping techniques. That can really indicate a lot of great information from a client for you when you're not together in a session. So that is that. I'm going to hand it back over to Susan, who's going to walk us through the complicated process right now of making referrals during COVID and what that looks like. Susan?
Thanks, Nicole. Yeah, so let's talk about this. This has become complicated, making referrals during COVID. And let's just highlight some of the challenges going on right now. I think the biggest challenge is that people are very hesitant to go to the emergency rooms during COVID. And so they may be at risk, but not wanting to go get help that they really need. If you are assessing a child that is really an imminent risk, or at least you're very concerned about it, the parents may be the ones that refuse to take that child to the emergency room. Just had a case last week this way. And a school counselor called and she was very worried. I was worried. I said, in any other time, this child would be in the emergency room, but there was one thing different that I recognized was actually a good thing that COVID has brought to us. Before, we would say we would not be able to keep that child supervised at home or possibly safe. But now both parents were working from home. All siblings were home. That extended family was all there. And so they said, we can keep this child safe. We will sleep literally in his bed, both of us, until we can get him to an outpatient setting. So, I thought to myself, well, there's something that COVID did give us that it wasn't there before. Trying to pull a positive out of here. But very, very difficult. And so one of the things that I think that, you have to really make your home safe. That's one of the things that we are talking to people about. If you feel like you have a child at risk, you've really got to make sure everything is safe in your home. And actually, SPTS will be having on their website a handout on how to keep your home safe during this time of COVID. That will be up there next week. But I think our challenges, and I actually spoke to the psychiatric emergency room this morning just to sort of check in exactly where we were at. And we are seeing, initially when COVID happened, we were seeing a very big decrease in phone calls and referrals to the emergency room because they believed that the schools were making most of the referrals. They did say that just in the last few days, people are getting really weary of staying inside, and those referrals, and people are showing up in the emergency room exhausted. They're not able to stay at home with the kids as they were trying to do before. So there is an uptick. There's also an uptick in psychiatric hospitalizations just in the last week or so. So I think that's powerful information. One of the things I want to just keep you thinking about is that if you feel that someone is at risk, the things that were there before are still there through telemedicine. You can always, perform care, the child clinicians, they're still there. The child clinician was actually not in the emergency room. She was actually on an off-site, so people didn't actually have to go into the big emergency room. They could go see the child clinician one-on-one. So they are making adaptations, but I also think that telehealth, we're just really trying to assess those soft skills in terms of looking at tone of voice, cadence, what are we seeing? And the child clinicians are trying to do the same thing. It's been a challenge. The police are still able to go out if you really believe someone is in danger. And the police are, if they see it with their own eyes, can make a transport to the emergency room. And if they do, if the screener tells the police to transport, they will sign a waiver when they get there. So there are many, many challenges right now during COVID, but remember the basic principles remain the same. And, it's just a little harder to negotiate through those avenues. Maureen?
Thank you, Susan. So I'm going to try to wrap up everything Nicole and Susan have shared with you. I think you could hear as they were talking that they've got a lot of experience. And again, what they're talking about applies across the life cycle. As you heard Nicole say, tell me more. Those are like magic words. They really are. They should be part of your repertoire for almost anything. My son and daughter-in-law have started saying it to, using it with their kids as part of better parenting. And my 11-year-old granddaughter says to them every time they say it, you sound just like a therapist. Nobody ever else says that question. So I think it's so important to make that part of your what you say to people. And again, you want that shorthand to really assess suicide risk. That was what Susan talked about in terms of those scales. I would always use that scale when I'm working with somebody, and I don't just use it for them, I use it for myself. It's a way to tell me if I'm empathically connecting with somebody. And I'm having some trouble with my...
Yeah, I'm popping on, Maureen, because there's clearly a bandwidth problem. So I thought that we just let you take a moment, see if there's just a lot of bandwidth going on in the world right now.
So let's let Nicole go through this. How's that?
Nicole's gonna go through it. Yep.
Sounds good to me.
Sure. Okay, guys. So taking over for me, Maureen, I'm just gonna move on to the next slide. Basically, advice from the field. Be honest with yourself about your reactions to suicide. That was the first step that we really, looked into today. And as Susan said, it's really important to be honest with those feelings. If you know that you're somebody who doesn't handle it well, we go back to self-awareness about our practice and how that will affect our ability to practice. Certain people have gotten into, scenarios or situations with clients, that they know it hits a little bit too close to home. So revisit those feelings regularly because they change. I can tell you all the time, some days you're just having more of an emotional time than you would have before. And maybe it just is something that is hitting you emotionally, that's clouding your judgment, your ability to act in the best interest of your client. And having that self-awareness actually even makes you such a better clinician. Remember, suicide is a crisis. You know more about it than you think you do. What does that mean? Take a step back and breathe. One of my mentors, has always told me, when you're in a crisis, the first thing we want to do is jump to act. The second you feel that impulse to jump to act, to do something, you pull yourself back, you take a breath, and you remember what it is that you do know. This is in your wheelhouse. You are able to help your clients problem solve and address those deficits in skills. If you don't believe you can help a suicidal client, refer. That's probably, in addition to your self-awareness, the strongest thing you can do as a clinician is understanding when this is outside of your capabilities and referring and make sure you have a strong referral list to ensure your client gets the best care. As somebody who, is a clinician myself, I get a lot of referrals strictly for, suicidal adolescents or students who have lost somebody to suicide. That's an area that I know I'm really good at. And there are some areas that I know I'm not the best. And I have a strong referral list ready to go when those things come up so that I can make sure my client has a great continuation of care. Remember, suicide remains primary focus of your clinical conversation. I think the biggest thing that happens sometimes is we acknowledge that the crisis is immediately over, right? They've gone, they've been assessed, it's been addressed, we're moving on. You need to talk about it for at least the next 3 sessions after you've determined imminent risk. Your clients will feel more comfortable. There is a slew of research that's available that shows the outcomes of clients who have this type of follow-up care do much better down the road and long-term than those who do not get asked the question afterwards of how they felt about the crisis and whether or not they're still feeling suicidal. So wrapping a couple of those up for Maureen, we're going to come in to some question and answer sessions. Maureen?
Yeah, thanks. And Susan, I think Susan's going to pop on too. We're going to just do these couple questions as a panel. There's a couple questions we won't get to right now, but I did want to answer a couple of them. Anything that doesn't get answered right now, we will put in the Q&A for next week's workbook. Susan, someone asked about whether the Columbia Risk Assessment for suicidality was still the standard that was being used.
Yes, that's one of them for sure. That's the one I use. I used to have it on the side, pull it out of my drawer, always refer to it, but I always incorporated it into that conversation. So I wouldn't read down it check by check, but I moved it into a conversation. So yes, the Columbia scale is an excellent form.
Excellent. And another question someone asked, Susan, that will really go right to you, was they wanted to clarify, are screeners going out to assess, or only the police are going out right now?
According to what I was hearing, the screeners are really trying not to go out. But more so, people don't want screeners in their homes because they don't know where the screeners have been. So it's kind of a two-way street. It's not that they are really, they're just beginning to start to ease up, and they said they believe that in the next week or so, they will be starting to ease up on that and probably going back out into the homes again.
Thanks. And this is, both of you can maybe go back and forth on this one briefly. What are some simple tools or strategies that parents can use to have conversations at their house to identify red flags with their kids?
Well,
I know, Susan, right?
that's a tough one.
That's tough. We can also, if you want to take some time and write it instead, if it's
no, it's okay. I think tools for really the real tool for parents is to open up that conversation and to really give the child time to talk and listen to what they're saying. And don't be afraid of asking those direct questions. So many parents are afraid of saying, are you thinking about hurting yourself? Are you having dark thoughts? It's a difficult question to ask as a clinician. As a parent, it's such a difficult question because the answers are so scary. But not to be afraid of that open, honest dialogue and to encourage those questions that are so difficult to get out. But the main thing is to listen to the answers without judgment. And don't try and fix it, and don't try and give advice. Just be with it.
One of the best resources that I found in previous years as a tool for parents is actually a book called When Nothing Matters Anymore. And that is by, oh my gosh, Cobain. And that's Kurt Cobain's cousin. And it's available on Amazon. I think it's like $9. And it is an excellent book. It's intentionally written for adolescents, but I've had parents have a lot of real good success in working with, their own children about it. So, it walks them through what depression looks like, how they get down into thinking suicide. I'm seeing, I let kids borrow that in my office all the time. Yeah, it's a great book. I mean, it's old too. And it the message just kind of comes across ages, like it hasn't been updated. And my kids that I have just absolutely love it. So, and it really gives parents a great understanding of what's going on in their kids' minds. So that's something that I always recommend too.
And Nicole, speaking about books, one that I think is awesome is Teen Talk. And it really talks to parents exactly what to say to a child as they go through so many different challenges, not just suicide, just even normal suicidal thinking, angst. So Teen Talk is another excellent book that I found helpful.
Thanks, Susan. All right, I think we have time for one more question before we move towards the end here. Someone was asking how to understand and interpret body language when you're on telehealth and you don't have access to body language. And I'm going to start that answer, and then Susan or Nicole can jump in. The first thing that I want to mention is that, yes, when we are on the phone or even when we are video chatting, we can't necessarily see body language, but body language isn't the only nonverbal communication skill we have. There's also that concept of paraverbal communication, which is not the words that we're saying, it's not what we're saying, it's how we're saying it. And that speaks to tone, pitch, and pacing. And just like people, if you lose ability to use one of your senses, the other ones can step up. When we can't see people and interpret body language, we need to increase and kind of hone our paraverbal communication skills, and especially our paraverbal listening skills. Really listen for, you can tell when someone's anxious. You might know that their pace picks up. They could gain an octave or so in their voice. You can tell, you can hear it. If you can't see it, you should be able to hear it. And the other thing I want to mention is that it's absolutely okay and it's smart to ask for body language cues. You can say to someone, you're sounding pretty wound up. Are you like at the edge of your seat? And they'll say, no, I'm leaning back, my feet are up, right? So you can check in and ask a question that will then solicit them to give you some information.
Yeah, Marnie, that's all great information. And what I think too, sometimes we like to throw the baby out with the bathwater, right? Telehealth isn't really all that bad. A big piece of what I'm hearing from a lot of clinicians and from a lot of people that I know who are in treatment themselves is that it's actually been nice not to have a face-to-face because they feel that they can be a little bit more open about things. I know that I previously had a client who some days would say, let's not have a FaceTime session because today what I want to talk to you about, I don't know if I can handle your own it gives us a little bit of a lead back. We don't have to worry about our reactions and things that are coming across. It's a little bit more organic. So, I think that it's to look for the silver lining that a lot of people are feeling a little bit more able to be vulnerable than they would in a face-to-face session.
Right.
I just want to bring out one thing that I think is really important is to ask whoever you're speaking to if there's someone within earshot that they're concerned about and they can't be honest with you.
Oh, so smart.
Because that is what I've been hearing so much from the youth is that I can't really tell you what's going on because my mother can hear me, or my father or my brother will rat on me and he's right here in the room. So I can't be honest. And somehow to ask those questions, are you in a place that's safe enough that you feel comfortable talking to me?
That's
I
great.
think that's a really important question.
Thanks, Susan. We're in the home stretch. Thank you for bearing with us through these questions. I know there's some of you have unanswered questions. Don't you worry. I will look towards them to make that work for you and get you answers in the workbook for next week. We're going to go on to the next slide, and Susan is going to cover that with us.
You put the next slide up. The poet Mary Carr has written, "Your mind can be a dangerous neighborhood. Don't go there alone." And I think you need to remember that even if you have to ask a stranger to show you the way, don't go there alone. For some people, you are that stranger. Just your listening presence can make the thought of suicide a whole lot less scary. And to use this with your clients as a metaphor will help them to, when your mind can be a dangerous neighborhood, don't go there alone. I am here with you and for you.
All right, and I'm going to wrap up with my favorite, Brian Andreas. So reminded again tonight that we're completely surrounded by stars in space, no matter how often we just stare at the ground, wondering where the magic has gone. So all of us sometimes need to shift our focus from the ground up to the sky. So that's just about it. As we end, my